Hello, today we're going to discuss heart failure pathophysiology. We're going to deconstruct the mechanical mechanisms of myocardial dysfunction, hemodynamic prophylactic targeting, mechanism and guideline directed medical therapy, all of this in one talk. Now, the core mechanism is a supply demand mismatch. There is an initial insult that reduces cardiac output. There's neurohumoral activation with sympathetic nervous system activation and renin-angiotensin system activation. There's increased afterload and fluid hemodynamic changes, and there's changes in stress and leading to toxic remodeling. This adds to the initial insult, and then the vicious cycle is initiated. Now, heart failure is often regarded in two buckets: heart failure reduced ejection fraction and heart failure preserved ejection fraction. There's also heart failure mid-range ejection fraction being recognized nowadays. Heart failure reduced ejection fraction is where the ejection fraction is less than 40%. The heart is weak and dilated. There's a pumping defect. Heart failure preserved ejection fraction, the EF is 50 to 70%. This is more like a systemic disease. There's a stiff hypertrophic ventricle with difficulty relaxation. This often associated with obesity, and the systemic derangements noted in this. There's also heart failure mid-range ejection fraction where EF is around the 45 to 50% range. Now, you can have left-sided heart failure and right-sided heart failure. In left-sided heart failure, the pressure changes back into the left atrium, into the lungs, causing pulmonary edema and shortness of breath. In right-sided heart failure, right-sided pressures increase, they back up into the systemic venous system and cause jugular venous distension, edema, ascites, and symptoms along those lines. Now, there are several triggers of acute decompensation. For example, ischemia as a heart attack, a STEMI, valve rupture, valve perforation from endocarditis. These last two would be mechanical traumas. Systemic problems that could precipitate heart failure include infections such as pneumonia, pulmonary embolism, patient factors such as non-compliance, having a bag of chips for instance, atrial arrhythmias such as atrial fibrillation. All of these can precipitate heart failure. Now, at the bedside, you can consider heart failure as warm and dry, where the patient's extremities are warm and he is well compensated. Warm and wet, which is the most common presentation, patient is warm and there is edema or congestion, crackles on lung examination. This pathophysiology needs diuretics and sometimes vasodilators. You have the cold and dry, where the patient is cold, and this is because of hypovolemia. There's a cold and wet, which is cardiogenic shock, which needs inotropes, mechanical circulatory support. Cardiogenic shock, the cold-wet spiral is defined by hypotension, systolic blood pressure less than 90, despite an adequate volume. The primary objective is to restore end organ perfusion without escalating oxygen demand. There's a low cardiac output leading to a compensatory vasoconstriction, increasing systemic vascular resistance, and mechanical circulatory support unloads the ventricle and breaks the cycle. Right ventricular failure is a distinct clinical entity. It's characterized by systemic congestion, preserved or low pulmonary pressures. It's highly sensitive to afterload, sensitive to hypoxia, hypercapnia, pulmonary embolism. Volume loading can be deleterious and causes interventricular septal bowing, drop in left ventricular forward flow. Now, you can figure these things out by using non-invasive measures, wherein you measure IVC with an ultrasound, measure flow in the hepatic and portal veins and renal veins, or you can use an invasive method such as a Swan-Ganz catheter. Swan-Ganz catheter allows continuous invasive tracking of flow, pressure, oxygen delivery. It's crucial for differentiating cardiogenic shock phenotypes, mixed versus cold. It guides titration of inotropes vasopressors, and mechanical support. You can measure the left ventricular end diastolic pressure indirectly by pulmonary capillary wedge pressure. If it is more than 15, then there is increased LV-EDP. You can measure cardiac index. If it's less than 2.2 liters per minute per meter square, there is tissue perfusion being compromised. You can measure pulmonary artery pulsatility index, PA pressure minus right atrial pressure divided by PA pressure, and you can also measure SvO2, which is a measure of oxygen extraction. If that's less than 60%, it's important. You can reverse remodel using guideline-directed medical therapy. ACE and ARNI are one pillar. Beta blockers are a second pillar. MRAs such as spironolactone are a third pillar. SGLT2 are a fourth pillar. SGLT2 works across heart failure reduced ejection fraction, heart failure mid-range ejection fraction, and heart failure preserved ejection fraction. Beta blockers should be avoided in heart failure preserved ejection fraction. In the 0 to 1 hour of heart failure, you focus on rapid decongestion, loop diuretics, vasodilators, oxygenation, propping the head up of the patient. They may need intubation, mechanical ventilation, etc. 1 to 24 hours, you identify the treat the precipitants. For example, do they need a cath for acute coronary syndrome? Does the AFib need management, etc.? Then, after the diuresis has occurred and you stabilize them on GDMT, you transition to oral GDMT and establish a multidisciplinary follow-up. Now, the pathophysiology of sodium is important to remember. Excess sodium holds intravascular fluid, directly increasing preload. Over 70% of sodium intake comes from processed and restaurant foods. Ideal limit is 1500 milligram per day. A single meal at McDonald's can give you more than 2400 milligram of sodium, and even 1000 milligram reduction drastically improves hemodynamics in patients. Finally, there's a continuous loop of heart failure care. Assess, intervene, and modify. Thank you for watching. More to follow.